Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
Hi, everyone. Welcome to another episode of In the Thick of It. My name is Dr. John Fritzlin. I'm a HCM cardiologist at the University of Kansas Medical Center in Kansas City, Kansas, United States. I'm joined across the pond tonight with Dr. Hunain Shawani. Welcome.
Thank you very much for having me on the show. It's really nice to talk about this topic.
We have a great topic tonight, and it's going to be centered on an article you published. Came out last year in JACC. It was titled Demographic-Based Personalized Left Ventricular Hypertrophy Thresholds for Hypertrophic Cardiomyopathy Diagnosis. And even though this came out a year ago, I feel like it's still gaining traction. We're having more and more conversations about this topic. And one of your colleagues, Dr. Moon, actually was just at ACC, this last week or two, talking about this as well. So it's important that we keep kind of talking about this and talking about diagnostic thresholds for left ventricular hypertrophy and HCM, because some of our, these criteria came about 50 years ago. Is that right?
Yeah. So I think if you go back into the literature, and Professor Moon is my boss, and he's sort of been guiding my hand through through this work. But we look back in the literature and we tried to find the first paper where we actually defined a maximum wall thickness threshold using millimeters. And the first paper was, back in the 1970s. And this paper was using M-mode echocardiography, and it was based around, I can't remember the number accurately, but it was 13 or so patients, and they were all male. And so when you think that that's the same threshold, and it's done it's done well. I mean, we've got as far as we have, and there are lots of things that we've discovered about the disease as we know it. I mean, when the first paper came out, it was still termed idiopathic. I can't remember the actual acronym, but IHSS. So again, it's gone out of vogue because that's how they defined it at the time. But the disease definition has evolved since then, but our ways of measuring it haven't. And this was a global effort to try and get that. How do we go about? We know that this is a disease. This measurement is affected by our demographics. It's affected by our body size, our sex, our age, and we haven't addressed this topic yet. So getting to this, it felt like we just why is no one asking the obvious question?
Right. That cutoff for 15 has kind of stood the test of time thus far, and certainly. The thought was above 15, it's going to be very specific, or try to be, but the downfall was we're going to potentially be missing people. And a lot of other areas within cardiology looks at indexes when we're talking about pediatrics, talking about patients younger than 18 we're indexing. We have mass index, different based on gender, men and women. There's even different sizes maybe for Eastern Asian people versus European. So there's a lot of indexing and personalization that has occurred in other areas of cardiology. But this 15 millimeter cutoff has kind of stood there for 50 years.
Yeah, and it's a great point that you raised about pediatrics. I mean, pediatrics understand this really well. They have a Z-score of more than 2. So, 2 standard deviations above the mean, that is abnormal in pediatrics. And that makes sense. And that's, and for everything else, we index it. We index it when we're measuring the atrial, we index it to atrial size. We index it to body size. We index everything else to the body size. But this hasn't been done in adults. And if you take, 15 millimeters, for some individuals, we know that the max, an average maximal thickness from older studies is could be 6 to 7 millimeters. And, 15 millimeters can be up to 6 to 7 standard deviations above the mean. And like you say, there are certain populations that are as affected if you are, a younger female. And we know that from the literature that, females present, it should be an autosomal dominant disease. So why are females outnumbered by males? Why is it a 2-to-1 ratio? Why are females presenting sicker? Why are they coming with more severe disease? Why are they presenting with more severe heart failure? I mean, I think the answer is clear. There is some underlying diagnostic bias in how we're addressing this.
Okay, so let's dive in a little bit and talk to me about how you went about setting up this study. How'd you identify kind of the populations to kind of analyze, and you guys selected cardiac MRI. Talk me through kind of the setup of your paper.
Right. So I think we started this idea. I think our foot into this was apical variant hypertrophic cardiomyopathy, and as we know, the apex is quite hard to identify with echo, but with CMR you get much better. You can identify it better, and we know that when you get to 12 or 13 millimeters in the apex, that's pretty big. That is, for the apex, that is relatively thick. And so we started with looking at these apical hypertrophic cardiomyopathy patients, and we came up with criteria. So actually, we said if it's more than an index to BSA of 5.6 millimeters, that is abnormal for the apex. But what really took us over the line and made this study possible was the machine learning tools we developed. So when they did the Framingham heart study and they went through lots of images and to set reference ranges, it took them a long time. You had to manually contour the thresholds, and there was problems with inter-observer and intra-observer variability. And so what allowed us to actually perform a study this big was machine learning. And so what we had to do, and again, we had a lot of stakeholders who were very keen, very interested, and very supportive. I have Vic Ferrari in UPenn and Harold Litt in UPenn, and we had colleagues across in Europe and Italy and in Portugal who were it was a global effort trying to get this study of the line and collect such a large proportion of patients. So we started with looking at a big healthy cohort. So we analyzed about 5,000 healthy patients. And we said, okay, this is, healthy subjects even, and this is what normal looks like. We've got the bell curve of what normal is, and now we have a standard. And we analyze this all with the same machine learning tools. We have a standard. Even, it may not be accurate, and that's some of the, arguments people may have, but there's no doubt that it's more precise because, we've now got a standard. And then what we said to look at is actually, let's now look at the general population. So if you're not aware, there's the UK Biobank, which is a phenomenal resource that we have, and it's a population-based study. And it's almost you go to the mall and people be handing out flyers like, do you want to join the UK Biobank? Do you want to get images? So it's a good population service, population level service. And there are 45,000 population-based people that we screened. And if you look at all those 45,000 subjects, we applied the criteria of 15 millimeters. How many would be diagnosed with hypertrophic cardiomyopathy? Because obviously it is a bell curve. There are people who will naturally be above 15. That's expectant population. But what was incredibly surprising to us is that when you looked at those above 15, 90% were male, 10% were female, and that's just it just sets we've set our bias from the beginning. And that to us was a huge problem. So that's what we identified first, and then our next step was trying to get this huge HCM cohort of patients. So we got about 2,500 subjects from 8 different countries to validate this against and actually see are we identifying trends in these subjects. And what we were able to do is show that actually in a lot of these females their thresholds should be much lower. They should have been diagnosed at maybe 13 millimeters or even less. And there were some patients who actually may have, sat on the cusp, and actually for them, 16 millimeters is normal. And you're thinking about those, and one point was really brought home to me when I gave this talk to someone, where they have these patients in their clinic, and they are just sat there at 15 millimeters. They're athletic and they can't, they've restricted their exercise. They're scared, they're because they've got this label, but actually they're at 6'3", large male. I mean, that's just normal for him. As much as his biceps are big, his heart muscles are going to be big. So, I think, and, this is not necessarily, this paper's not the, be all and end all. We have developed a tool and we've developed these, sort of these thresholds. And if you're interested, you can go to hcmcalculator.com and say, actually, this is my, demographics. What do what would normal be for them? But it's the start of a conversation. I think what you say is very interesting. A year on from the publication, we're still getting traction. I think we just have to get the message out there. People still don't, buy that actually you can have, this needs to be observed. We need to be looking at this in the context of what your personalization and, how your demographics affect your actual maximal thickness.
Yeah, that's I mean, so important and the impressive that you guys were able to take it to this scale. And when you guys looked at your HCM cohort, already like a fourth of the women were already below that 15 millimeter sort of cutoff. So these are from HCM centers who are kind of looking at things just, outside of that 15 millimeter, cutoff, had other features, whether that was genetic testing or family history or EKG abnormalities, but they had, an HCM expert thought that they had HCM and were, less than 15 millimeters. So you guys were able to kind of take this MRI, data and age and, gender, cohorts and apply it and improve the diagnostic, yield in some of these cohorts. So, where did it make the biggest difference? Was it the young females?
Yeah, it was young females who, were small in body size. And I mean, what you say is quite correct. That these are HCM experts. They know what they're seeing, is HCM, but, they may be restricted by thresholds. And, when you're seeing a scan and it just looks abnormal, and you've got the caliper, you can change it to whatever you want. It takes only, a pixel or two to go from, 13 to 15, or, and if you've got the sense that it is, and that's what clinicians are doing. That's what we know. It's not the number is not necessarily what's important, but it's the whole clinical picture. But I think what this tool allows you to do is gives you the freedom to say, actually, I'm right. I know what I'm seeing is, HCM, and as Professor Moon, let's say hocomoid, scans, they just give you this feel like this is a HCM patient. But, this tool gives them the ability to do this, to say, actually, this is what I think it is. And, even using an objective CMR measurement, these patients still fill under criteria.
Now, certainly that this is going to help kind of retrain kind of how we look at things, but this was all based with MRI, and one of the sort of challenges is that not every kind of patient who's possibly has HCM is able to get a cardiac MRI. Tell me a little bit more about some of the limitations, or how can we kind of expand this potentially to echo?
No, I think you raise a very good point. I mean, echo is the first time modality, and this is what most patients are going to be seeing in the office. They're going to be scanned with an echo, and they may not even see us, inside of a magnet. And that's what we expect. And we know that the intra, modality differences, there is a 1 to 2 millimeter difference between an echo measurement and a CMR measurement, even if you've done everything as, you've optimized the imaging as much as possible. I think we've opened this up to actually say to the echo people, can we validate this with echo? And we are doing work towards trying to get normal reference ranges for echo as well, and looking at maximal thickness. And it is a different, it's the threshold is we found slightly lower, that, maximal thickness is smaller in echo than it is in CMR. But I think that's what we need to go to. We need to find something that fits with echo, because that is what you'll be seeing. I think the risk is, when we over generalize things with CMR, is that it is people can think, oh, okay, that's just a big academic center, that's where, this is for that. I mean, that's not what we want. We want this to be, we just want to democratize the findings. And I think things like using words like machine learning, artificial intelligence, and automated scanning, throws people off that actually that's very academic. It's like, no, we just want to get the concept across. So, even if you've got, echo and it just looks, you look at your whole patient, and hopefully this just has people to think that actually maybe I shouldn't be relying on the number, and just look at the patient and just think about what the scan's looking like for me. But I think the question is, I mean, that's where the future needs to go. We need to get this out into echo. And if there's anyone who actually wants to, watching this and, wants to get involved and actually has a big echo data set, say, hey, we can help, just let us know.
Yeah, that's going to be a really important step, and hopefully we have some people take you up on that. So talk about other sort of limitations to this study. Now, if we have patients who have like, hypertension or, valve disease, did those sort of, comorbid conditions get factored into, hypertrophy?
Yeah, so that's a very, very good question. And I think it's very pertinent. I think when we created this healthy cohort, we excluded people with valve disease and hypertension. So this is for patients who have no comorbidities. In our HCM cohort, we did have patients with hypertension. We did have patients with, some valve disease. And, I think, I can't remember the stats off my head, but at least 15 to 20% of subjects with HCM will have concomitant hypertension. And there's that gray area that's actually difficult to exclude. So I think what we've done here is we actually created a definition of inappropriate hypertrophy. But we haven't necessarily made it as specific to HCM. And I think the next step will be to actually try and find out, well, can we adjust for hypertension? But unfortunately, I think it's a very murky area to go into. The deeper you go in, the more questions you end up asking yourselves, because what is hypertension? Is hypertension someone with a BP of 141 systolic, or is it someone who's on 5 medications uncontrolled for years? And how, what's the time course effect of the hypertension, how has it affected their heart and the remodeling of their LV? And so I think it's a hard question to answer. And I think we need more data. As with anything, the more data we have, the better. But hypertension is one of those questions where, and the question that we actually asked ourselves when we looked at this, there were patients who were, they were below their, if I recall correctly, they were below their adjusted maximal thickness, but they were still above 15, but they had hypertension and they were male. So was that hypertrophy because they were just hypertensive and, they've just managed to fall into a HCM clinic and that's where they are? That's a good question. And I think the other with athleticism, with hypertension also comes athleticism. Where does athleticism fit into it? If you are a very athletic individual, you're a veteran athlete, how do we account for that? I think that's the other question that we need to answer.
Yeah, that's certainly where the art of medicine comes in, and recently I just saw kind of a 80-year-old male for kind of second opinion for HCM and had maximum wall thickness of 15, so that they were sent, but using your calculator, he was right within kind of range, and we kind of talked through some of this. So I think it's already impacting sort of my clinical practice using that calculator, which I think is helpful to have these sorts of conversations when we're kind of in a gray area. Do you have a sense that these sort of personalized thresholds are going to make it into guidelines one day, or is it too early to tell?
That makes me so happy to hear that there's actually even one patient that's been affected by this. It just that's what we want out of this. I do hope that guidelines start to reflect that we should personalize it. Again, I think we've just started the conversation with our paper, and it was a collaborative effort. We needed a lot of hands to help us get this over the line. A lot of people involved, a lot of stakeholders. And I think the hope is that the next iterations of the guidelines start to reflect the need to personalize thresholds. But I think it's difficult for people, if you've always done something one way, if it's not broke, why fix it? And it's in this gray area here where, is it life limiting? Are they symptomatic? I don't think stuff like this is going to change whether you put an ICD in them or not, because you need much more hypertrophy. But it's that picking up people a bit earlier, people picking up people on the cusp where it becomes useful. And I hope that future guidelines do reflect it.
Oh, absolutely. I think the last couple of years have just kind of shaken up HCM for a number of different areas in terms of medical therapy, in terms of diagnosis. So this is kind of certainly in a renaissance of HCM right now, and really appreciate all that you and your group have been doing to kind of help push forward, the diagnostic sort of criteria and evaluation for these patients. So really want to, applaud you and your team for all your efforts.
No, thank you very much.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.